I am Shirley White Walker, and I wear many hats. I'm a nurse midwife. I'm a mom and a grandmom. Actually, I have two different jobs. I was the person that retired, and then I had two jobs, not one but two. My first job is I have 2 days a week. I work in an HIV clinic with HIV positive women and provide all of their women's health needs. Just starting to initiate an IUD program there. You know, we want to prevent unnecessary pregnancies. And the other job I have is I work in a federally qualified health center. And I'm doing straight OBGYN. I do family planning, prenatal, postpartum, whatever it takes. Unfortunately, I'm not doing births, and I miss that. I miss the smell of amniotic fluid. I could do it again, but it's going to cost me more, financially to get back into that practice because most places, they want you to either work full time or if they hire you as a per diem, you have to pay for your own med mal and everything else. And I'm thinking, why am I going to spend money to do this? I mean, it doesn't. But we'll see. One day I might wake up and say I miss it enough that I got to go back and catch again. It was 2008 when I stopped working, and so you figure 2012. So it's like 4 years I hadn't touched a patient when I went back to work. And I was really worried that I would not remember how to take care of the patient. Not so much the how to interact, the interpersonal thing, but worried about the clinical piece. Did I remember the meds? Do I need to carry books with me? Do I have all my resources together? And it just, honest to God, it came back to me very easily. I was very happy. I didn't take a refresher and just jump right back in there. And I thought to myself, oh, who the hell do you think you are? Did you think you could be out of practice for 4 years and just fall back in there? But I did, and it worked for me. So, of course, I do use my resources and my references, as needed. But I was surprised. But I think that was because it was 38 years uh, before I quit. So I graduated in '76. I went to work in 1977 at UMDNJ and University of Medicine and Dentistry of New Jersey. And that is where the first and only midwifery school was in the state of New Jersey. I have the dubious distinction of being the first African American midwife to graduate from the first school of midwifery in the state of New Jersey. Well, that and $1.50 will give me coffee at McDonald's. The thing was, it wasn't so much the distinction of being the first African American, but it was the distinction of being in the first class, in the first school. When I graduated and I went to work for the same school that I had gone to for my training, so I wasn't getting a new experience. I was walking back into a familiar experience because the laws are strict. You couldn't work until you actually had a license in your hand. So it was almost a year after I graduated before I actually had a license in my hand to practice. There was no such thing as a GN, a graduate midwife. That you could hang out with the CNMs and you could you could observe and that kind of thing, but you really couldn't do any patient care. And either you were a student or you were a CNM, but there was no recognition of the in-between. And I stayed in that job for 15 years. I have only had two midwifery jobs in my career until when I quit work and then went back 2 years ago, and now I'm in two different places. But 4 jobs is all I've ever had in my entire midwifery career. For 32 years, I only worked in two places. So I don't know what that makes me some kind of anomaly, because most midwives I know are kind of like nomads. They move from here to there. But I think one of the things that kept me in place was, family constraints and so forth. But I've had a blast. I often wonder to myself if my experiences had been different, if I had gone, out of the state, or even for integration. Um, Integration being that aspect of midwifery where you're pulling it all together and you're actually functioning as a CNM. Integration, most people go out of the state, they go to a different practice, they go elsewhere. But my director knew, I had a young child, and my mom was like mommy number two. She was kind of helping me with the kids, and she knew it would not have been practical for me to go to Texas or, Oklahoma or somewhere to do integration. And so very wisely, rather than stress me out altogether, I mean, she said, well, you can stay right here, do your integration right here at UMDNJ. And then transitioned into a job. I enjoyed the patient population. I worked with teenagers. That was my first job. I worked in an inner city. I worked in Newark, New Jersey. I worked with teens to begin with in the MIC project, which is the Maternal Infant Care Project, which was developed strictly for teenage mothers. And that was an eye-opener. It was a very exciting time. There was a lot of drugs going around in the 70s and the 80s, and patients were appreciative of the care they received, and they would try to pay me off in drugs. Patients would say, I brought you a little gift, expecting they would bring me hand lotion or maybe something to eat, cookies or whatever. And they'd hand me a tin foil of cocaine. Here, this is for you. Oh no, I don't do drugs. Oh, but my boyfriend, the dealer, sent this for you. And so I stopped being shocked. I stopped being shocked about the things I would see and the things I would hear. And I embraced the community, because the women that I took care of I called them the patients who don't have a choice. And because they don't have the choice to go to a private physician or go to a private midwifery practice, they're quote-unquote default provider. But I never wanted any patient to ever feel as if, I'm stuck with her because that's all I can do, and so I have to put up with. Now, I always felt like every patient was my daughter, my sister, my cousin, my niece, my whomever, because there but for the grace of God. I mean, who knew? Who knew I would become a midwife? That is the question that has a multifaceted answer. I became a midwife because I felt like I didn't know enough to do what I did. I was working as a charge nurse at night in a maternity unit. And I had what they call a mixed unit mixed type unit. It was postpartum, antepartum, and GYN, pre and post op. So I had patients who were diabetics, preeclamptic, all pregnant, cardiac disease, whatever have you. And this was a small community hospital. I had my postpartums who had delivered, and then I had the GYN surgeries. Your tubal ligations, your Marshall machete procedures, your hysterectomies, your whatever have you. And I was the only RN at night. I had working with me an LPN, a couple of OR techs, nurses aide, kind of stopped with me because it was expected that as the RN in charge, I would direct the rest of the staff and the proper ways to do whatever. And I wasn't what you call terrified, but there were times that I was doubtful about whether or not I should be doing what I did, because I'm thinking, okay, I'm in charge. They're looking to me for direction. I don't know if I know enough to be responsible, but for these 44 patients, and because every bed was always full, and plus the staff, because these patients have complex problems. They didn't teach me all this in nursing school. The OJT, they tell you, okay, well, diabetic, you got to check her sugar every now and then. If it gets above this, do this and that. But I don't understand the whole physiology as clearly as I should with pregnancy and so forth. So that was part of it. I was already feeling kind of, I don't know, uneasy. One night I was working, and it was about 2 o'clock in the morning, and I heard Code 8 postpartum recovery room. And I knew that somebody had crashed, they needed CPR, etc. So I jumped up from the desk because it was 2 a.m. I'll admit I was, my head was snapping, you try to stay awake. And anyway, I ran down the hall to labor and delivery, and I said, what happened? What can I do? Is there something I can do to help? And they said, yes, this woman is bleeding out, and, we're trying to find out what's going on with her and whatever. I said, what can I do? What do you need me to do? I need you to, get some IVs and get this and get that, do this and that. So I said, okay. The patient had lost so much blood that she literally had blood in her hair. She had blood under her feet. And, my eyes are huge. My eyes must have been like saucers because I couldn't understand. Well, what are you going to do for her? Well, the code team was on the way, and they resuscitated her the best they could. Meanwhile, the attending came in because the attending was not in hospital. It was an intern. And the nurse said, one of the nurses said to me, I kept telling him, I think it's a laceration because she's not gushing blood. It's that trickle that you get with a laceration. So, I'm watching and listening, but I never worked in labor and delivery as a nurse. I didn't really get the distinction or understand, exactly what they were saying. The attending comes in and says, let's take this patient to the OR and we'll look at her and see what's going on. So they put her on the table, do an exam, and he says, yeah, this woman has a cervical laceration. So he turns to the intern and says, do you know how to fix this? And the intern says, yeah. He says, all right, we'll fix it. And he turns on his heel and leaves the hospital. The intern tries to repair the cervical laceration, but obviously did not know how to do it properly. And so he'd catch all the bleeders and so forth. And they wheeled the patient out of the OR into the recovery room. This time she codes again, but she codes for real. It's gone. She's gone. No turning back. This is like baby number 5 or baby number 6 for her. And her husband's in the waiting room. He's pacing, he doesn't know what's going on. They're calling codes. They're not telling him anything. And this woman died. I was mortified. I was in shock. It wasn't my patient. It was not any, I didn't have any personal involvement other than to do whatever I could, whatever I was asked to do to help. But I was devastated. I was literally in tears because I said, why did this happen? This is, why? What happened? I talked to my good friend Carol Green, who had just finished Columbia as a midwife, went to midwifery school, Columbia. And I said, Carol, I don't know why this happened. I said, could they have done anything? Or she said, yeah, if he had known how to properly suture laceration, she probably would not have died. I said, well, is that something that you learn in midwifery school? And she said, yeah. She said, if you had gone to midwifery school or you had the knowledge of a midwife, you could have saved this woman's life. Well, that was too much for me. To think that there are people walking around with a title of certified nurse midwife who could actually make the difference between life and death, that you will learn enough that you can keep mothers safe. And it was overwhelming. Carol had just finished, was in Columbia at the time, and training as a midwife. She got a job at UMD&J as faculty. So Carol came to my house unannounced one morning. I was sleeping, because I told you I work nights. And she said to me, I want you to sign this application. I said, what application? What is this? They're starting a midwifery school in Newark, and I think you should apply. I said, no, I don't. My husband and I had recently parted. My baby was a year old. She was born in 74. I went to school in 75. I basically said, I really can't do this. She said, no, I just need you to sign the application. I said, well, I can sign. That's nothing. She says, and I need $10. And I said, I don't have $10. I have to go to the bank when I get up later on, blah, blah, blah. I said, no problem, I'll put the $10 in. Long story short, Carol said to me, I know how much it affected you that woman died. And you felt like if you had only known more than you know right now, you might have been able to help her. And I think you should go to midwifery school. And I said, I think you're right, because I don't know enough to do the job I'm doing. So off I went. It was interesting being in the first class, because we were kind of like it was federally funded, my program. The government paid, our tuition was not, it was tuition free. And we had a certain stipend for books and daily living. And really, it was in response to, I guess, whatever studies they had done that realized that there would be fewer or not enough women's health providers in the future, and that it was a pilot program to see whether or not they could educate nurse midwives to be able to take on many of the roles traditionally held by physicians. As I said, I was in the first class, and that was being a guinea pig in the first class. Was a real eye-opener, because there are things that they taught us that nobody knows. The doctors don't even know that stuff. I mean, just obscure, of course we learned the basics, and we learned how to be effective and competent and provide quality care, but we learned obscure things, like we read the studies about how long it took somebody to literally exsanguinate. Who needs to know that? You're hoping you're going to be effective in stopping the bleeding before any of this happens. But anyway, I went to midwifery school on the heels of that experience, but it was profound for me, because I just felt like, it's so simple. Now I know it was simple. I didn't know then how simple it was. Obviously, if it's a tear that goes into the lower uterine segment, you have a different story. But I'm talking about simple cervical laceration can take somebody's life. It's not hard to fix, but you have to know how to do it. When I say it hit home for me. I had never had anybody in my family that I knew of that, died in childbirth or any kind of related kind of situation. But I don't know, maybe that was my way of, or somebody's way of pointing me to where I needed to go. I don't know. I have never, ever in my life regretted going to midwifery school and becoming a midwife. I mean, it's been a joy all my life. Because I live in the community that I worked in for so long. I live in Plainfield, worked there for 17 years. I see people in my daily walk of life, people I've delivered their babies, women I've taken care of their, family planning or GYN needs, and it just becomes, I can't shop in the supermarket. Somebody says, oh, Shirley, hey, good, let's see it. I want to tell you, I have this pimple. And you go, call me, call me at home. The last baby I delivered at the hospital I formerly worked in until 2008, the last baby I delivered, I saw her last Saturday and took her to the movies with me and my granddaughter. And it was just nice to see her. You know, it was just like, wow. Her mother stopped by unexpectedly, and I said, hey, I'm sorry you came now because we're on our way to the movies. And then the little one said, can I go? So her mother said, well, if it's okay. I said, sure. But it was just like amazing. This is a living human being who's talking and doing all the things that children do, and enjoyed the movie. We went to see the Muppets, and so it was just nice. It was nice to see her, nice to hear about my kids. I see a lot of my children in, various things. My granddaughter is a sophomore in high school, and she was talking to one of her friends one day, and come to find out I had delivered her friend. And, so it's fun. Midwives in other countries are held with so much more esteem and honor. I don't want anyone to honor me. I don't want people to, bow when they see me. But midwives are respected and looked up to in other areas of the world. This is the only country with the highest infant mortality rate of a developed country, but I'm not going down that road. But this is the only country where midwives do not have a place of honor within the system, because we are seen as superfluous. Why do we have midwife? What do you need a midwife for? You need a different point of view. I mean, you don't want to have somebody who's technology focused all the time. You need somebody who's hands-on focused, who's focused on natural. I always used to tell students that because you train in a high-tech environment does not mean that that's all you should have in your armamentarium. I like to feel like you put the technology in its proper place. You pull it out when you need it. It should not be what you start with. You start with the usual natural methods of comfort, of evaluation, assessment, and if you need to pull out, do an intrauterine pressure catheter, or you need to screw in an electrode, or you need to do something fancy, be able to do it, but that shouldn't be your first go-to. The issue of how a midwife is viewed in this country, and the gender and the race and the so forth, I think it has to do with poverty. I think it's the social piece. The majority or all of my career, I have taken care of underserved, medically underserved, and sociologically disadvantaged women. And nobody really cared whether I gave them quality care or not. I cared. But nobody was really concerned that you may not be doing the very best for the patient. Other than, okay, I have to say the FQHC, because they had federal standards that had to be met. Because the patient is viewed in society as a, quote, a throwaway patient. Nobody really cares. The patient doesn't have any money, says nobody's losing any money. The patient doesn't have any esteem, any clout, if you will. They don't have any stang, as the young people say. So it's not like she's going to call up her senator and say, listen here. So that patient is the patient who I want to give all I can give to, because nobody gives a damn about that patient. Politically, I have been in discussions many times with people who said, I remember when the hospital I was working at was closing, and I went to see and it was bought by another hospital. And I went to see the president of the medical dental staff of the hospital that bought my hospital. And I said, I would like to work out something so that we could still continue to see our patients. We have a caseload, excuse me, of about 1,200 prenatals. Where are these patients going to go? What will happen to them? And they said, well, it's not my problem. You have to work out something somewhere with somebody, but, it's not something that we can do. So I said, do you think it would be possible for us, and at that point, the us was, I went from one midwife starting this midwifery service in the FQHC to 8. We were doing somewhere between 800 and 900 births a year. In 2005, we had the second lowest C-section rate in the state of New Jersey, and that's a midwifery practice. So when I talked to this gentleman, he said to me, well, it's not me. He said, I don't know how the rest of the OBGYN department would feel about it. I said, who, like the chairman? And he said, yes, Dr. Such and such. And I said, oh, I trained him when he was a resident. I'm sure he would let me and my staff come. And he said, well, he's not the only one. There's other people. And he said, and if I stood on a corner and I swung a bat, I'd hit an OBGYN on every corner. And I said to him, and how many midwives would you hit? And they said, none, I wouldn't hit any. I said, and that's my point. If a patient came into this hospital right now and said, I want a midwife, who would you call? There's nobody. We are the midwifery service in Central Jersey, He said, that's not my problem. It's not something we're concerned about. Patients will get care. They will get care from physicians like they always have. And this is just a fluke. This is kind of like a trendy thing, just like people were, using hula hoops. They'll have midwives. And I was mortified, and I said to him, I know what it is. These patients are poor. The majority of my patients were ethnic minorities. I said, because they're poor and they're minorities and they have nothing, they don't bring you any prestige. If they deliver here, nobody's going to come and do a story on them and say, oh, Mrs. So-and-so and so, or Miss So-and-so and so, maybe she wasn't even a married mother, delivered here. I mean, it's real clear. It's real clear what this is about. He was pissed. I was pissed. When the meeting was over, everybody was jawed up. I was tight when I got back to work. I just couldn't imagine. So what is going to happen to these patients? So what happened to the patients were the CEO of the health center where I was, the FQHC, made an arrangement with a hospital that was 25 miles away. So women showed up at the hospital that nobody wanted them at anyway because it was closer, right? The midwives could not go with them, could not be a part of their birth, but they managed to go there and they were mistreated because the story that was being said to them is, you're the reason why such and such hospital closed because you poor people, you couldn't pay, and the hospital closed as a result. What a horrible thing.